very similar to palliative care. It's care that's focused on quality of life and symptom management and supporting folks through the trajectory of their illness and or illnesses. And it's really meant to reach people where they are and help educate them about the underlying disease process and help them cope with that. A lot of times folks that are on supportive or palliative care not only have better quality of life, but actually longer quantity of life. So supportive care, those that are having challenges with the burden from the disease itself and or the treatments of the disease. So a lot of times we think about people undergoing, traditional chemotherapy that may have nausea, may have pain. So those are people that are definitely eligible for supportive care, but also patients with non-cancer diagnoses. So those with Alzheimer's, dementia, or other forms of dementia, in addition to congestive heart failure, emphysema, or chronic obstructive pulmonary disease. So those typically that have diseases that are chronic and progressive in nature, or that have acute or diseases that, unfortunately hit them real quick. Patients often with cancer, sometimes you hear these scenarios where out of the blue, unfortunately, they got diagnosed. Those are all patients that are eligible for supportive care. So primary complex illness care is for those patients that we just talked about who need a supportive care touch, but also either don't have a primary care provider, or unfortunately their disease process has progressed to the point where they're starting to have limitations in their ability to transfer, to get back to their primary care physician's office, to get to other multiple physicians' offices or see them. And obviously with the advent of telemedicine, they still may be able to see them to some degree. But those are patients that we will come to their home and see, or several chronic progressive illnesses that need a primary care provider that are debilitated to the point where they're not able to make it back to their primary physician. Those are the patients, because we appreciate, all the primary care physicians and nurse practitioners out there. Found is this is sort of the next step in the natural progression of supportive care, just that next tier of patients that we found in our experience who could benefit from that kind of approach. So we're covered by Medicare or Blue Cross Blue Shield or Aetna or Cigna or TRICARE, just some of the more Medicaid. We're paid just like any other specialist is, or any other, if we see for our version of primary care, if you meet those qualifications, just like your primary care provider would be paid. It's the same mechanism, so there's no additional payment. We do think there is great value in what we do. On average, we spend 70 minutes with our patients. So we do invest a lot of time. And again, our patients tend to have a higher degree of complexity. It's not just us physicians; we're actually outnumbered. We have more nurse practitioners than physicians, and our nurse practitioners do a great job. We also have social worker that's dedicated to the program and just hired a second one. We also have a nurse that's dedicated, and we're in the process of recruiting for an additional nurse. We have 3 full-time coordinators dedicated to scheduling and making sure that patients get things they need, whether it's medications, durable medical equipment, what have you, as well as a manager and director of medical services in order to provide care to the communities that we serve. You do need a referral from your current physician or specialty physician or nurse practitioner or other provider. We do request a referral just because we want to make sure that we're seeing patients appropriately. We can help facilitate that referral if need be. If you need us to have a conversation with your current primary or specialty physician, we're more than happy to do that in order to facilitate that. But we do need a referral in order to see you.